Thank you. It's a little bit intimidating to speak about external wire balloons when the inventor of external wire balloons, Ron Solar, is sitting on the panel. So please don't correct me, Ron, if you would, on anything, but he has certainly been a luminary in this field. So obviously, symptomatic peripheral arterial disease is often the result of long lesions, either in the SFA popliteal or infrapopliteal space, and therefore, longer balloons and stents have been developed. Long balloons now up to 30 centimeters in length are available, and I suspect we're going to need longer in the future. And developments in crossing technology make intervention a possibility in almost all peripheral arterial disease patients. So why am I standing up here in front of you talking about balloon angioplasty? Hasn't that been around a long time? Well, it actually has. The very first cases of percutaneous angioplasty came from Dr. Charles Dotter. And in this, he used a series of progressively enlarged rods to open vessels. This proved that dilation could indeed open stenotic or occluded vessels. But really what made this field explode was when Andreas Grunzig decided to use a balloon to stretch open areas of blockage rather than a series of progressively enlarging rods. Now, the mechanism of how balloon angioplasty works is now understood a little better. Initially, Andreas Grunzig described this as like compacting snow. Well, that's not the mechanism at all. What we have is plaque fracture, stretching of the vessel wall, and lumen expansion. I remember someone calling this magic dust. How on earth could you put a balloon up, deflate it, and expect for things to improve? Yet it often did. But there are certain tenements of balloon angioplasty that no one can argue. To start with, the bigger the channel we can make, the better, because flow is related to the fourth power of the radius. Therefore, even minor increases in luminal size transmit far greater flow. However, there is a Goldilocks phenomenon at play here. Angioplasty is a form of controlled injury. If we don't stretch a vessel enough and make a big enough initial channel, we get elastic restenosis, elastic recoil, and therefore restenosis. However, if we stretch the vessel too much, we injure the vessel. We get neo-intimal hyperplasia, and that results also in restenosis. So this is a Goldilocks phenomenon. So why optimize balloon angioplasty? Why speak about that today? Well, because balloon angioplasty plays a critical role in almost all cases as either the definitive therapy, as most cases of infrapopliteal disease, or as preparation for stenting or to further dilate post-atherectomy or to deliver drugs. We now have all sorts of balloons, drug elution balloons, focal force balloons such as VascuTrack and ULTRASCORE, Angiosculpt, cutting balloons, chocolate, which may have its own characteristics. But today I'm going to really focus on external wire balloons. Now, there are many clinical challenges that balloons face. First, highly calcified lesions that don't want to yield, very long occlusions, plaque that involves bifurcations where shift may occur, highly resistant lesions, and small below-the-knee vessels. Now, what are the theoretical advantages of long balloons, and why did it take so long to develop them? Well, to start with, theoretically, you can dilate everything you need to dilate in one setting, therefore it decreases procedural time. That's important. That also causes decreased radiation exposure. Also, when we inflate a balloon, we obstruct flow. Therefore, there's less vessel occlusion time and potentially less risk of thrombosis. I think there's also less risk of emboli resulting from advancing and withdrawing wing balloons, which we have to use with shorter balloons because you have to dilate overlapping segments. And finally, there's less risk of dissection as dilation is from a normal segment to a normal segment, which has historically been shown to yield less severe dissections. So what were the theoretical disadvantages? Slower inflation and deflation times. Balloon bowing, the balloon actually developing a banana shape. Plaque is heterogeneous, and some areas would dilate very easily, while others wouldn't open. And so in order to open up the highly stenotic calcific areas, you would apply a lot of pressure and overdilate some areas. And of course, there's more winging. So the problem's the plaque because it is different. So what we want to really do is minimize trauma. And to do that, we want to limit strain. And strain is how fast we pull a vessel open. Think of Play-Doh. If we take a ball of Play-Doh and pull it apart quickly, it rips apart in 2 balls. But if we pull it slowly, it stretches. What we're trying to do is stretch, not pull apart. So we have many studies that show that low pressure inflations minimize trauma. So the solution in this case is to use a stress concentrator, and that is an external wire, which allows us to inflate at lesser pressures. This can enhance luminal enlargement and improve PTA results by reducing strain. So the first of the devices that Ron developed was called the VascuTrack balloon, and it used the wire that you crossed with, coupled with an external wire on the balloon. And these wires created about 300 times the force at the site of that wire, allowing slow, steady inflation with the balloon. A newer iteration of that is called the ULTRASCORE. It's over the wire. This balloon has nice support, and you can see it uses external wire. And the wire actually focuses the balloon inflation force. This causes vessel hoop stress relaxing as longitudinal expansion is created. It allows you to slowly stretch the vessel open. Again, there have been many reports that this gives better reports. Now, focal force angioplasty creates a controlled longitudinal stress pattern. This results in slow stretching, better mean luminal gain, lower recoil, and hopefully less injury. These are some examples. These are from Neto Inouye showing dilation of a posterior tibial calcified artery with focal force balloon. Here we see a long occlusion of a popliteal segment, again, dilated with focal force balloon. Despite calcium, a nice result. And finally, this is a case from our lab, a patient with a long occlusion of the popliteal segment into the tibioperineal. And you can see this was balloon alone and the kind of results that one can achieve. Now, if we look at this using optical coherence tomography, you can actually see the spots where the wire led the way, allowing you to more gradually and slowly expand the vessel. We think that this sort of technology can indeed improve results with balloon angioplasty alone. Thank you for your attention.